Then we put the aneuploidies markers in perspective. We'll go through basic interpretation and risk assessment of these markers, a bit of basic counseling so that you know how to handle this information, and then of course onto the last bit, which is what's new, what's changed, and a bit of perspective on why it has actually changed. The reason why Down syndrome is important is not just the things that I told you already, but also that it's not so infrequent. 1 in 650 live births, and some believe it's 1 in 600, some 800, but basically 1 in 650 live births. They have major quality of life issues, and on top of it there is the long lifespan, which means that they will live a fairly full life in terms of years, but they will need assistance all along, and that is where the problem lies. Some families accept the fact that they can do something for them, other families accept the fact that they're not able to do this for them, and therefore the patient would like options. In addition to Down syndrome, of course, there are additional common aneuploidies at birth, and these include trisomy 18 or Edwards syndrome, trisomy 13 or Penta syndrome, and all of these can be, to a certain extent, assessed by the same screening protocol. There is also the option of being able to look for monosomy X, triploidies, and the sex chromosome abnormalities, but for now we'll concentrate more on how we go about trying to figure out the most significant of these aneuploidies, and that is Down syndrome. Now, the first thing, of course, is the word screening. Why do we need to screen? Screening, as we know, is to look at an entire population to be able to identify those individuals who will benefit from further evaluation. Now, why do we need to screen for Down syndrome? The specific diagnosis of a chromosomal anomaly is by an invasive procedure, which is either a chorion villus sampling or amniocentesis. And these have an inherent rate of fetal loss, somewhere between 1 in 200 for beginners and somewhere between 1 in 800 to 1 in 1000 for the experts. If we take the beginner, say 1 in 200, it means that if all pregnancies had amniocentesis, then one normal fetus would be lost for every 4 cases of trisomy 21 that are diagnosed, and obviously this is not acceptable. Now, if that is not acceptable, then we have to move on to something where we do realize that we have to move on to a method which is acceptable, and that is by reducing the possibilities of having miscarriages and yet try and detect as many as possible. And that is what screening is all about. And of course there are economic considerations. Even in the most advanced of economies, we do understand that we cannot afford to do an amniocentesis on everybody, and therefore we go into screening. And when we go into that process, we realize that there is a method by which we can do this. Screening tests, as you know, are to find people at a risk. This means that they can get earlier, potentially more effective treatment and make informed decisions. And about 4 decades ago, we realized that we can move on from just the detection of anemia, blood group, syphilis, etc. in pregnancy to expand into assessing for Down syndrome. And this used to be done by a 20 to 22 weeks anomaly scan combined with a genetic sonogram of the second trimester, and we will discuss this briefly again today. There was a window that appeared later on, so that now the window of diagnosis is the 11 weeks to 13 week 6 days scan, followed up whenever necessary, of course, by the anomaly scan and genetic sonogram, and therefore this is how we now go about it. The important thing to understand about screening is that any type of screening and testing, there is a possibility of false positive results and false negative results, and this is something that we must clarify to the patient right away. A screening result that shows that there is a problem when a problem does not exist is called a false positive result. And this means that you can't use the screening process as a final process. It has to be followed up by a diagnostic test to figure out whether a positive result is a true positive or a false positive. The second thing is that a screening test result that shows there is not a problem when a problem does exist is a false negative result. This means that we will not identify all pregnancies when we go through a screening program, that there would be some that would be missed, and the aim of all screening programs is to identify as many as possible, which means reduce the false negative rate and also reduce the false positive rate. And this is why things have evolved even in aneuploidy screening, where what we're going to discuss today has evolved to try and identify as many more pregnancies as we can with the condition, and bring down the false positive rate. Now, the point where we begin this whole process is to realize that we want to reduce the number of invasive testings that will not yield a positive result. We also want to reduce the number of invasive testings on the kind of cases where there might be more precious pregnancy, so to say. Also, we do realize that the changes that are happening today are because of unreliable serum screening in certain situations where the quality screening is not good. Also, if the quality of evaluating the radiology markers or the ultrasound markers is not right, which is an unreliable nuchal translucency assessment. And the important thing, therefore, is to realize that we must have a good quality screening test. The currently used screening test, of course, is good quality if it's done properly. And ultrasound and biochemistry are screening tests, and these identify pregnancies that are more likely to have a trisomy 21 fetus and should therefore be offered diagnostic testing. The next step in all of this is to do a procedure that will yield material that will then be sent to the lab for final diagnostic testing. And these procedures are chorion villus sampling at the 11 to 14 weeks window and amniocentesis at the 16 to about 22 weeks window. Of course, choreocentesis is something that we used to do earlier but is no longer that frequently used because we now have the advantage of amniocentesis material being handled appropriately. Once this material is obtained, it can be then used in ways to give a result such as FISH, which gives an image like this, and this will then tell us whether there's a trisomy or whether it's an euploid state. It has been largely replaced by QFPCR, where the report looks something like this, and the advantage of both FISH and QFPCR is that they're available very fast, the turnaround time being somewhere between 1 and 3 days, and therefore you have a quick answer for trisomy 21. The gold standard so far has been the culture with karyotype, and this is now being largely replaced by microarrays, which are a little more better at seeing what is going on and therefore can give us information, and not only just for the chromosome numbers, but chromosomal abnormal arrangements within the chromosomal moiety as well. So FISH, QFPCR, culture with karyotype and microarrays are diagnostic tests that will finally give us the answer on whether there is Down syndrome or not. So essentially, therefore, screening tests, which is ultrasound and biochemistry, procedures, which is CVS or amniocentesis, and then the actual diagnostic tests. In screening, we look for what John Langdon actually described many, many years ago. He first told us in 1862 that the face is flat and broad and destitute of prominence, that the nose is small, and the skin is deficient in elasticity, giving the impression of being too large for the body, which means this is what it looks like. And this was immediately translated then over the years to try and identify and see something similar on the ultrasound scan, which is the edema at the back of the neck and the abnormal nasal bone. The description even by Langdon Down had to be repeated in 1887 because nobody believed him, and therefore this actually marks what happens in biology a lot of times. We do realize that we have to make an effort to drive a point home, and hopefully we will drive this point home appropriately as time goes by. The first realization that we could do biochemistry came in early 1980, where we realized the maternal age-related risk for Down syndrome, which was 5 and above, where there was a sharp increase in the incidence of Down syndrome in the babies born to these mothers. In 1984, we were able to identify that reduced fetal AFP levels in Down syndrome were present and that this information could be exploited. And in 1987, we realized that HCG levels, which were abnormally high, were also linked with Down syndrome. And therefore, the story began, which means that we were able to combine this and finally put together the triple test for screening for Down syndrome. Where it stands today, we will come to in a little while. But what has been happening since then is that it was quickly supplanted by early 1990 by the quadruple test by the addition of dimeric inhibin A, and that improved the sensitivity for detecting cases of Down syndrome. By 1991, it was realized that even in early gestation you can have a marker, and this was PAP-A. And by 1992, Kypros Nicolaides had shown us that a nuchal translucency scan in the first trimester of Down syndrome could be done, and that nuchal edema could be identified, and that this could be used as a good marker for Down syndrome at a much earlier stage. By 1997, a good test was in place, which is the maternal serum screening and the nuchal translucency scan, and of course this has been perfected over the years. And of late, of course, we have realized that we now have a newer modality, the non-invasive prenatal screening, or NIPT as some people like to call it, non-invasive prenatal testing, which is a very highly sensitive screening test which gives us a much higher detection rate and a much lower false positive rate. The evolution of ultrasound is shown here on this slide, and Beryl Benassara from the US showed us in 1987 that the nuchal edema was shown here, as we see here, which is the green area, and that measurement was taken from the back of the skin. That is, the outer margin was the outer margin of the skin, and the inner margin was the surface of the occipital bone. And this was called the nuchal fold, and is still called the nuchal fold, and remains one of the most important signs in the second trimester evaluation for aneuploidies. It's seen in the same axial view in which we look for the cerebellum, and as you can see, this view will also always show us the cavum septum pellucidum. The first trimester image is a mid-sagittal image, and this has been the essence of what we see today, and we will discuss this as we go along. Essentially, it's an image that shows the tip of the nose in front, the nasal bone behind that, the palate showing in between, and then of course brain, and then finally this lucent area at the back, which is truly the nuchal translucency, and that is what becomes edematous in aneuploidies and other similar conditions. Now, how have these changes shown us a difference in detection rates? Well, here it goes. In general, the second trimester changes, which were actually discovered far before the first trimester screening markers were discovered, did not do too badly if you went on to the quadruple test, which means about 70 to 75% detection rate. But do remember that the triple test, which is maternal age plus serum alpha fetoprotein, free beta HCG, and free histriol, has a detection rate of only about 65 to 70%, and not universal as some people believe it to be today. In fact, we have to tell patients that, look, although this is an inexpensive alternative, it is probably the least sensitive of all our alternatives. The quad test, to which we've added the inhibin A along with whatever was in the triple test, has a better detection rate of about 75%. When we move to the first trimester, if we have maternal age and nuchal translucency, just one ultrasound marker, we increase our detection rate to 80%, a straight jump of 5 to 15% over the biochemical markers of the second trimester. If we use only maternal age and first trimester biochemistry, which is free beta HCG and PAP-A, we are back to what is the detection rate in a triple test. Not acceptable. If, however, we combine maternal age with nuchal translucency, with free beta HCG and PAP-A, the combined test, so to say, we have an 85 to 95% detection rate. All of these come at a false positive rate of 5%. If to the combined test we add either nasal bone or tricuspid regurgitation, or we add ductus venosus flow, then we realize that our detection rate jumps to as high as 96%, and importantly, our false positive rate falls down to 2.5%, half of what it is otherwise. And therefore, obviously, first trimester screening is far superior. If we were to take maternal age alone to try and screen for Down syndrome, we would miss 70% of Down syndrome babies, and that's completely unacceptable, and therefore by itself maternal age is not something we use anymore. The argument against this kind of screening of the combined test is that we now have a test that works better, and this is NIPT, or non-invasive prenatal testing. It is based on the fact that placental DNA fragments from the placenta, goes into maternal circulation, and the laboratory is able to test it and try and find out whether there is trisomy 21 or not. What has become apparent over the years is that this is not just enough, and that when we get a good report that we can depend on, the amount of fraction of placental DNA in the maternal circulation that comes from the fetus has to be at least more than about 4% to be able to get a reliable NIPT result. And as a consequence, therefore, we have to take measures that will make sure that we have enough of a fetal fraction. And this can be ensured by making sure of a few things. A, that the fetus is at least about 10 to 11 weeks of gestation, and that the fetus is alive. If we don't have this information, the NIPT goes horribly wrong. And therefore, it's obvious that we cannot dispense with ultrasound completely at all in the way things are going at the moment. So if we have to pick on a good fetal fraction, we need to know that. Also, then we can get to know the viability as well as the number, which means that NIPT works differently for twins in terms of the algorithm, and it works differently for multifetal pregnancies, and therefore we cannot do without a first trimester sensible evaluation for all of this. And the algorithm that now works, therefore, is very, very straightforward, that we do need a first trimester scan. And the good thing is that it's been extended to not just aneuploidies but a whole lot of other things, and therefore forms what is called the extensive change in our thinking, which means we diagnose earlier and earlier, and we get answers earlier and earlier, and we give not only answers for aneuploidies, but we give answers for a whole lot of things, including structural defects, screening for preeclampsia, growth restriction, and preterm labor, which actually constitute a much larger amount of disease in the mother and pregnancy than Down syndrome by itself. You can also assess for maternal pelvic pathology, and of course screening for aneuploidies comes out naturally from this entire performance. So that is the way the system works as of now. With the advent of NIPT, there has been a change, of course, and we'll discuss that later in terms of invasive procedures and in the way people think. But in general, we do realize that things will change if we use this information correctly. But to show you how it actually works, say we take 100,000 women who've had a quad test and 100,000 women who undergo NIPT. The prevalence of Down syndrome, let's presume, is 1 in 500. The detection rate is 80 for the quad and 99 for the DNA. The false positive rate is 5 for the quad and 0.2 for the DNA. The false positive results by the quad would be almost 5,000 out of the 99,800, and the false positive on the NIPT would be down to 200. The odds of having an affected fetus is 1 to 31 for the quad and 1 to 1 for the DNA. So obviously DNA is the way to go in the future, but it's something that we must take with a pinch of salt to make sure that we carry out the test in the way it's meant to be carried out, not as a direct to patient sales approach, which is completely wrong in biology in the first place. Now, the calculation of what are the chances of having Down syndrome are based, of course, on ultrasound markers predominantly, because as you realized, that is what gives us a great base by itself to go by. Maternal age plus nuchal translucency, giving you a screening and detection rate of about 80%. And then, of course, I mentioned already the nasal bone, the ductus venosus, and tricuspid regurgitation. We did add on a few years ago the facial angle, which we dropped because statistically it didn't mean much, and the hepatic artery because it just followed the line of the ductus venosus and was more difficult to do. So obviously we'd opt for a test that was simpler and give us the same kind of result, or a marker that was similar and gave us the same kind of result. And the ones that are now currently used, therefore, are what I've highlighted here: nuchal translucency forming the backbone, and the nasal bone, ductus venosus, and tricuspid regurgitation for refinement of risk. And of course, in a screening program where the payment is out of pocket, then usually people who screen either from fetal medicine or from radiology would like to offer all ultrasound markers for a full answer. So let's start off right at the beginning, and let's say who should be screened. You've already realized that we can't just confine ourselves to women who are over 35 years of age, because that's only 30% of Down syndrome babies. If we look at the age-related risk, we do understand that there's this huge tenfold change between the ages of 25 and say 35. So if at 25 we have a risk of 1 in 1350, At the age of 35, we have a 1 in 350. And of course, at the age of 45, a risk of 1 in 35. But what this data essentially says is that since there's a risk even at a young age like 20, every single woman who is pregnant should be screened for Down syndrome. And therefore, there is no question of using this. But do remember that age is important to be mentioned correctly. We can't go by approximation of age like a lot of our patients do. So if it's approximate, then that should be indicated in the patient data that we're not sure of the patient's age and she's probably approximately 25 years of age. Also, in this day and age of ovum donation, we have to use the age of the ovum donor and not the mother that is carrying the pregnancy, and that is important to indicate, otherwise we end up getting a wrong answer. The second question we need to answer is, when should we screen? If we look at the chart here, we realize that PAP-A, which is low in the aneuploid fetuses, is far lower than that of the euploid fetus at about 10 weeks of gestation. And the value of PAP-A is almost equal to the euploid fetus at 14 weeks of gestation. Beta-HCG is about the same. So if we are to take advantage of this lower PAP-A, then we must do a biochemical screening at about 10 weeks of gestation. If we want to see the fetus better, which is what we do now, because we like to do a structural assessment also, then this chart tells me that when the fetus exceeds 63 millimeters of crown-rump length, I can see a lot more structural abnormalities. So ideally then, I need to screen my fetus with ultrasound at 12 weeks and biochemistry at 10 weeks. But it's inconvenient for the patient, and therefore a large number of clinics and setups now actually compromise and say, okay, we'll do everything at 12 weeks and then finally give them a result. But the ideal way, of course, is biochemistry at 10 weeks and ultrasound at about 12 weeks. Now, let's move on and realize that the first step is not the identification of the marker, but the identification of the age. And for this, we use the crown-rump length. We use a window of 11 weeks to 13 weeks, 6 days. But it's better to indicate it by the crown-rump length because the software works best between 45 millimeters crown-rump length and 84 millimeters of crown-rump length. And this should be therefore indicated. Also, that there are certain very, very clear things that we have in the crown-rump length, which means that the section must be a true sagittal section. The fetus should be in the neutral position, which means there has to be fluid between the chin and the chest. And the neck should not be too flexed or too extended. That it should occupy a large amount of the screen and at least 2/3, and you shouldn't be able to fit in a fetus in the remaining space. And of course, sometimes you can use a zoom even post-freeze, but ideally you should be using it pre-freeze. You therefore need to do a lot of effort when you do these, and that is important because if you have a fetus that is in this position or this position, you're not going to be able to do your test correctly. You have to wait for it to come into an ideal position and then do a crown-rump length assessment. And therefore, an image like this would be more appropriate than an image like this where the outline is not well seen. And do remember that even in twins, you need a good crown-rump length for both because they could have different crown-rump lengths. So we don't compromise on this at all. And then you move on to the nuchal translucency, where again, it's important to remember this image because even if you're not doing your own scans, it's important to know whether a good image is a good translucency image, nuchal translucency image or not. Because if it's not, then a minor variation in the measurement of the nuchal translucency is going to kill your screening process and give you an abnormal result. So the image must contain the tip of the nose, the nasal bone, the zygoma, the mandible here, and the zygoma should not show up between the nasal bone and the mandible, and the palate, sorry. And then it should show us the midbrain here. Then we should be able to see the future fourth ventricle here and the future cisterna magna behind it. And right at the back here, the lucent area should be well seen, and that is the nuchal translucency. The section again is not this one because this is not true sag. The section again is not this one because you see something between the nose and the palate. And then of course the chin is too close to the chest. It should be like I showed you before, all of these areas seen clearly. Also at the back you have to watch for the fetus to jump so that you can make sure that you're not mistaking the amnion for a nuchal translucency. And therefore, time needs to be spent on this whenever it is being done. And never be in a hurry to give fuzzy images like this. They don't actually work. Also remember that the fetus might be appropriately magnified, but the background might be too much, and then again that is not correct. And images like this have to be rejected, and the person who's doing it has to be informed that this is not right. When we go on to a cord around the neck, which is not infrequent at this stage, we do understand that the nuchal translucency will be narrower where the cord goes around, and it'll be a little bigger below and above. So you measure the nuchal translucency above, you measure it below, and take a mean of the two, and then you get to know the true nuchal translucency. The placement of markers is important, and we use the plus marker only, and the horizontal line of the plus should be flush with the actual white of the margins of the nuchal translucency. So anything that is outer is not appropriate, anything that is halfway through is not appropriate, anything that is way out is not appropriate, and also if there is a curve, it must be absolutely perpendicular to what is going on and not at an angle as shown in this particular image. And therefore images like this are not actually good, because this one has too much of the thorax, and this one is a very good image from the landmarks, but the posterior marker here has been placed too much inside the skin for an appropriate result. Here we notice that the chin is too close to the chest, and here the magnification is completely inappropriate. So in each one of these you will not get the right answer. There is also automation, which has modified the way we look at some of these things, but it has to be supervised, and in that supervision you have to realize that the markers must come correctly, and if they don't, then it's better to do a manual marking. Once you've done the nuchal translucency, you put it onto a chart, and we don't use the old figure of a cutoff. It's convenient to use cutoff, but that's not the right way to do it. What we have to do is to make sure that you realize that the nuchal translucency changes from a CRL of 45 millimeters to a CRL of 85 millimeters, and it's much low at the lower end, about 1.2 to 2.1 at the beginning, and up to about 2.7 millimeters at the end. And therefore you must interpret the nuchal translucency in terms of the crown-rump length and not just as a sharp cutoff. There is no doubt that nuchal translucencies that are more than 3.5 millimeters are more frequently associated with an abnormality, and that the thicker the nuchal translucency, the greater the chance of an abnormality. But we don't use a cutoff. We always use it in an appropriate perspective. What we also need to realize is that a large number of normal fetuses will have a thick nuchal translucency, and therefore this is not to be used as a diagnostic test. It is not the basis on which a termination should be done, and we should not yield to the patient not wanting to go through the hassles of a diagnostic test and terminating on the basis of this screening test alone. And this is extremely important to realize. Let's move on to the next marker, which is the nasal bone, and we use exactly the same image for it as we use for the nuchal translucency, and it is parallel to the line of the skin above. And remember that we don't actually measure it at this stage, but we talk in terms of whether it is present or not. We know that the cartilage is always there. It's the ossification that gets delayed, and it might ossify later, but even if it ossifies later, it does not alter the risk here. And therefore we have to be very careful in looking at the nasal bone. The presence or absence is enough, but typically if we measure it, it means we focused much better and we know the edges far better. Moving on to the others, ductus venosus is the next, and we look at it because of aliasing that we're able to see in the abdomen, and we always use color and a section that uses only the upper part of the thorax and down to the upper part of the abdomen. And then you look for the typical S wave, D wave and A wave, and we look for forward flow at the end of the A wave. Now this is seen in 80% of trisomy 21 fetuses. It's also seen in about 5% of normal fetuses, so we don't start terminating on the basis of this, because that could be a normal fetus. The older cutoff was reversed flow, and this is no longer true. What we now use as a cutoff is the pulsatile to the index, so even if there's a reduced forward flow, that becomes significant, and therefore this is what we use now. In fact, this is independent. It means that a fetus that has a thick nuchal translucency might have a normal ductus venosus, or a fetus that has an abnormal ductus venosus might actually have a normal nuchal translucency. So it truly improves the detection rate. However, it requires skill and time, and therefore is not that widely used. But ideally speaking, is a great way to fine-tune your screening and the risks. Tricuspid regurgitation is again related to trisomy 21 and cardiac defects. It's also related to increased NT and not as great a marker as the ductus venosus. It disappears as the CRL increases, but it does enhance the performance of first trimester screening. But you have to use the criteria correctly. The heart has to have the apex pointing anteriorly, a four-chamber view of the heart with only the entire thorax occupying the entire frame. Then, of course, you have to look at the amount of backflow here. And when you see that, you have to make sure that the gait is right, 3 to 4 millimeters of gait. The degree of regurgitation should occupy at least half of systole, and the dip should be more than 60 centimeters per second, and take 3 readings and use an average. So that's the way you go about these 4 ultrasound markers. What about ignoring biochemistry? Do remember that there is no association between the thickened NT and biochemical parameters in the abnormal fetus, and therefore, ideally speaking, we must combine them to enhance detection rates, which, as I showed you in the beginning, ultrasound plus maternal age plus biochemistry is better than ultrasound plus maternal age or ultrasound plus biochemistry. Therefore, we must use all this as a combination and then come up with a risk. This risk is based using an appropriate model, which always adds on the NT, the CRL, the PAPE, the free beta HCG in the background of maternal weight, ethnicity, IVF, number of fetuses, and smoking. And then you get your answers in terms of what is the risk. Do remember that a lot of patients don't understand what a risk means, and you have to sometimes re-explain it in terms of what it implies. For instance, you could say, look, there's a chance if you go out to your office from home, you might have an accident. But that does not mean you stop going to office every day. And this is important to give these kind of analogies so that patients actually understand, and also to understand that different labs would display the risk differently, and you have to be familiar with that. Also, that the cutoffs are not always sharp, and although they're redefined by Kypros Nicolaides almost every year at his World Congress, there are some good guidelines which will encourage you to help your patients make the right decisions. One is that usually the risk is greater than 1 in 10. That's very high risk. You offer invasive testing. If it's somewhere between 1 in 10 and 1 in 50, you give them the option of NIPT or invasive testing. If the risk is less than 1 in 1,000, you just go back to the routine mid-trimester scan and do a genetic sonogram at that time. But if you have a risk of somewhere between 50 and 999, that's when you might want to add on the additional parameters for refining your risk. And some patients at this stage might actually want to add on the option of an NIPT. And therefore, you often have different cutoffs. But for the moment, what I've shown here is what we're using. Now, do also remember that a lot of people are giving a radiology risk or an ultrasound risk, which is maternal age plus ultrasound markers. Then a lab is giving maternal age plus maternal characteristics plus biochemistry, and they're completely different in terms of risks. And you can't take one, add the other, get a mathematical average and give a final risk. No, it has to go into a proper formula. Also, each marker refines the risk. So the first background risk is age, then is maternal characteristics, and then if you've added on biochemistry, you add those. Then if you want to add on nuchal translucency, you add that on to the risk calculated by the first 3 calculations. And if you were to add on a quad test, you then add on the quad test to the risk obtained from the combined test. You don't use the quad separately. This is also known as integrated, and that is the correct way to do it, and not randomly use each one. And this is where the new stuff has come along, because now you also have a T1 quad, which is age plus historical factors plus PAPE plus beta HCG, PLGF, which is for preeclampsia, and alpha fetoprotein, which helps you to look more carefully for neural tube defects when the patient comes back. This is something that is perhaps going to prove useful if you have unreliable ultrasound. In our background in India, we generally tend to have labs that are not keeping up values, but ultrasound that seems to be a little better off, and therefore we now have a first trimester Penta test, which means combined test. That means the age plus CRL plus maternal factors plus NT plus PAPE and free beta HCG plus nasal bone plus alpha fetoprotein plus dimeric inhibin A and PLGF, placental growth factor, with an excellent screen, very high screen for aneuploidies as well as a great screen for preeclampsia. So this is the direction into which we seem to be moving over the next few years. And do remember that each new factor will add on differently. Remember also that if you don't actually use this thing properly, you're not going to be able to answer your patient's questions correctly. The other good thing is that when you use a lot of these in a combined manner, the result is always better and the detection rate goes up, and the more parameters you use, the better it is, and this applies to the newer markers as well. Now, moving on to the next bit, which is the fact that we are changing. We do understand that we also have a role of a change of the second trimester markers, which means that whereas previously we used to have the Nicolaides method or the Benacerraf marker method of present absent, we now have a meta-analysis by Gatha Cleos in 2013, which has replaced the original set, which is ventriculomegaly, increased nuchal fold, aberrant right subclavian artery, and absent or hypoplastic nasal bone is more important, and the rest is less significant. For each of these, you have a positive likelihood ratio and a negative likelihood ratio, and then you multiply that, add it to the risk obtained from the combined test or the quad test, and then give a new risk and help the patient to decide. Before we close, a few words of wisdom. When is screening not required? Some patients will always request a direct invasive testing. This is usually patients who are relatives of babies of Down syndrome. Or they are just too anxious and they will insist, then they don't require screening. Then there are some patients who will not terminate for religious or other reasons, and therefore screening is not required. You just go ahead and do an anomaly scan, and that also only if they wish to do one. And so I'd like to conclude by saying that, look, Down syndrome can be diagnosed during pregnancy. Diagnostic tests are invasive and have an inherent miscarriage rate, and however small it might be, but they're also expensive, and therefore we need screening tests which identify those patients that can move on to diagnostic tests. Screening tests by definition cannot identify all affected pregnancies, and first trimester screening is far more effective than later screening. And therefore, let me say that it would be worth it to take home this message. Please do screening, give it your best, and do it right. Thank you so much for your attention.
सर एक शॉर्ट चीज हो स्टार्टिंग में जैसे इंट्रो भी होता है ना, हाय गाइस दिस इज ये स्टार्टिंग होता है जैसे आप बोलते हैं हाय गाइस दिस इज
too much of a lag, but was that between the speech and the pointer, or it was only between the...
No, speech and pointer was okay. Whatever you were saying, the pointer and speech was all going together.
Oh, okay. So we just run these through. These are teething problems. It's nice we run these before in advance, before we have too big an audience.
Yes.
And we'll do it. There we are. Khatam. Oh yeah. Thank you very much. Inshallah. This is all for you.
Thanks a lot.
That's it.
It is for you.
Oh.